This one's going to be a hard one. Okay, so starting at the top of the head, things are pretty symmetrical there. Shoulders, pretty symmetrical. Chest, yeah, a lot of bone uptake. What about the pelvis?
Right.
Well,
I'm sorry, that's that.
okay,
No,
we have
that's
some
the
activity
right.
there, right? So what's usually going on in the left iliac fossa of the pelvis? What do we normally put there? Okay, kidney transplant. It can go on the right or the left. It depends which blood vessel is the best of the two.
Is that infiltration in the left wrist?
Injection site.
You know, it looks like it to me. Oops, you talk about right over here?
You missed.
Is that the injection site?
Well, you know, this is why it is so important that you guys put down where you inject it. Because yeah, if that's not an infiltration, then that could be something else going on. I don't know, remember the story of that girl in Florida right now, the one that has the flesh-eating bacteria?
Really?
Oh, no, she's still alive, but they've cut off both of her hands and
That
her leg.
bungee jumping?
Yeah, she was bungee jumping and she cut her leg. She got MRSA, or not MRSA, but it's a staph aureus. I don't know, but the thing is that she's had her legs cut off. She's had flesh-eating bacteria. They normally have to surgically go in there and remove the tissue because, yeah. And she's only, I think, like, yeah, she's not very old.
Yeah, there was a girl in my class, she got carjacked, and then she was drugged under her car. And yeah, she got flesh eating, they had to amputate the whole leg. It's pretty bad, it's like, it's a death sentence.
Yeah, that's not good. So, anyway, this is a kidney transplant. And sometimes when the kidney's being rejected, you'll see a lot of white blood cells in there. One of the tests we used to do for rejection was to inject sulfur colloid, and we would compare the amount of sulfur colloid in the kidney to the amount of sulfur colloid in the femur and the surrounding bone. And if it was higher, that meant that there was a lot of white blood cells in there attacking the kidney and rejecting it.
Why is the rib cage so focal on that one?
Well, again, remember that it's being picked up by the RE system. So, and with renal transplants, remember the patient's probably getting a lot of steroids. Yeah, well, they're getting, well, I mean, so to prevent rejection, and so probably as a result, a lot of the white blood cells went into the bone marrow. Otherwise, you probably see a lot more activity in the pelvis, especially if it was being rejected. But that used to be one of the criteria that they would do for rejection. Okay. But again, false positive indium studies. Accessory spleens, remember people could have more than one spleen. Okay. This one here, the activity, if you have a sore throat or you have a sinus infection, you can, you know, hack up a loogie, as we used to say, and swallow it. GI bleeding, okay. If you get an infarct, okay. Remember, as the tissue starts dying, white blood cells go to that area. Okay, same thing, pulmonary infarct, lymphomas, remember they're white blood cells. Okay, inflammation. So even though you don't have an infection, but anything that causes an inflammation. In your days as a anatomy and physiology student, one of the things that my teacher did was they scratched their arm. If you scratch your arm, what happens? Huh?
Potentially red skin.
Well, you get a red line where you scratch, right, where the fingernails were. And that's your body reacting to a potential injury or potential break in the skin. And that's what they're talking about here, is an inflammation where it doesn't necessarily have to be an infection to be an inflammation. Now, the next thing we're going to talk about is gallium. And gallium, like I said, it goes back to 1969. They use it mainly for, right now, imaging lymphomas. In the handout that I gave you, towards the back it says tumor localizing agents, and there's a thing on gallium. Yeah, a little test there. But okay, first started out for, they were originally using it as an abscess imaging agent. The characteristics of it, notice it's produced in the cyclotron. You bombard zinc with a proton, so it's a PN reaction. Decays by electron capture, half-life of almost 3 days, 3.5 days. The gamma peaks on it. Okay, this one, we typically do 3 peaks when we image it, if we have it available. The 93, the 184, the 296. Then remember there's also a 394. Okay. Typically, or originally they used to inject, or they image at 4 to 6 hours, but because of the cost, the insurance companies don't want to pay for that extra imaging. So typically you're going to do 24 and 48 hours for infection, and you'll do 48 and 72 hours for tumor imaging. Okay. Typically you do a whole body, then you do spot films of areas that are abnormal, or you may do SPECT imaging. Now, as far as the patient preparation, and this may have changed because we used to do bowel prep on patients. Okay? And some of you may do it, some of you may not. Does anybody do gallium? Ashley, saying, have you guys done gallium scans?
The only time I've ever seen them do gallium is for the spine.
For the spine? Did they do delayed images on the patient? Typically, because gallium is excreted through the liver and it winds up in your intestines, we do serial imaging. So in other words, we do the delayed imaging at 24, 48, maybe up to 72 hours to see whether or not the stuff moves. If it stays in the same location for the 24 and the 48 hours, then there's probably something there. But if it moves along, then we don't worry about it. But what I put down here, the patient preparation, regular diet, says on 3 p.m. on the day before the scan, the patient drinks water every hour until 7 p.m. The reason being, we don't want the intestines to retain the gallium in there, because remember, when a person gets dehydrated, the kidneys don't release any water, and the intestines keep food in longer to try to suck out as much water as it can. So we don't want the gallium to be retained in there as a result of dehydration. It says at 4 p.m. on the day before the exam, the patient takes magnesium citrate. Now, there's 2 types of laxatives that can be used. But again, a lot of places don't do any bowel preparation anymore because it is physically demanding on the patient. So you may or may not do it. But this hyperosmolar laxative, when the patient drinks that, it has more particles than the surrounding cells in the intestine. So it draws fluid out of the intestine and literally flushes out the colon. Okay? But I put down here, if the BUN or creatinine are abnormal, then don't use it. Because, what does that mean? Yeah, it means the kidneys aren't working properly, and if you give this stuff, the patient's going to become very dehydrated, and you're going to probably shut down the kidneys. So you don't use a hyperosmolar laxative. Castor oil is what they call an irritant laxative. Okay? Castor oil is also, or castor beans is what they get ricin from. Does everyone know what ricin is? Yeah, it's a very deadly poison where there's no antidote for it. That's why you don't want to go around chewing castor beans, okay? Because it will kill you, and there's not a thing we can do for you. It's a horrible way to die. It killed this Bulgarian newspaper thing that the Russian agents shot him with a pellet that had ricin in it. They had an umbrella that had a little thing that injected this little tiny pellet into him, and it took about 3 days for him to die. It's not a very pleasant way to go. But going back to this, so castor oil, you give 2 ounces of castor oil, and that will clear out the intestines. But it's a very violent, unpleasant method of preparing bowel.
Tear it apart.
If you don't like somebody, it's a great way to get back at them. Dulcolax tablets are also another type of laxative. It's a little bit milder, but anyway. And the patient is NPO after.
How can you give them castor oil? I thought castor oil has the poison in it.
Well, no, the oil doesn't have it's in the bean casing itself.
Okay.
But if you separate the oil out from it, you got to be very careful though when you do that. It's a real challenge. So, but actually the ricin is thought of as a potential terrorist weapon of mass destruction. Actually caught some guy up in Las Vegas making a batch of it, or trying to make a batch of it. I mean, it's real easy to make, but I mean, as soon as somebody says, "Hey, I'd like to have a few pounds of castor beans," everyone's going to be looking at it and be like, "Okay." They'll probably have the FBI and CIA and everybody over there. Okay, so, but this is kind of an extreme thing that most people are not going to be doing too much. Typically, after you inject a patient, for the 24, the 48, any of the delayed scans, they could prepare the patient. Okay? The laxative is typically given to clean out the small bowel, and then it says on the day of the exam, so the patient at 7 a.m. in the morning gets a cleansing enema. Okay? That's a full prep. That's something, if you were a patient, you would probably rather die than go through 3 days of this. Okay? So, laxative day before, and then a cleansing enema before you go down to the department. But now, as far as like what they would use it for, first of all, there's only certain cancers that will pick up gallium. Okay, bronchogenic cancer, hepatocellular cancer, some testicular cancers. What they really use it for mainly is lymphomas and non-Hodgkin's lymphomas. Okay, both of those get picked up pretty well. There are some lung cancers that will pick it up, some melanomas and metastasis from melanomas that will pick it up, and some neuroblastomas. See, these aren't 100% guaranteed, and that's why the sensitivity and specificity aren't as high for tumor imaging. Yeah, you can do it, but it's not always a guarantee. Okay? What it was mainly used for is this, inflammatory imaging. Okay, a fever of unknown origin, FUO, not a UFO. Okay? An FUO, by definition, is a cyclic fever lasting more than 3 weeks. I put that in there just so if you ever see that as a diagnosis, usually FUOs turn out to be cancer or tuberculosis. But basically, you have a fever, it goes away, comes back, goes away. That's what I mean by cyclic fever. Abscesses are real good for gallium. Osteomyelitis, so you do the 3-phase bone scan. You can really confirm it with either the gallium or the WBCs. Pyelonephritis, Remember we talked about infections of the kidney, so that's one. The bad thing about gallium is that usually for the first 24 hours it is excreted through the kidneys, so you can't make a diagnosis of pyelonephritis until you do the delayed images at 48 and 72 hours. You do that. And then bowel disease. Then we've got some other stuff here, this pulmonary inflammatory disease, sarcoidosis, pneumoconiosis. This bleomycin is a chemotherapy agent that can injure the lungs, but if you injure the lungs with that, it causes an uptake in the gallium. So, moving along here, what's interesting about gallium, we talked about the white blood cells being attracted to areas of infection, because usually it's chemotaxic stimulation. Chemotaxic is the stuff that draws white blood cells to an infection. Gallium, notice it says that it's bound to protein. And typically what happens is that it stays attached to that until it gets to a site of an infection. At the site of the infection, let me just, where did I have it here? Hold on just a second. Let me go back here for just a second. I need to get back to my camera because I'm having okay. The way that it's transported, it's with transferrin, which transports iron in your blood, and lactoferrin, which transports lactose. But the thing here, okay, here's an interesting question. Can you do the technetium white blood cell and the gallium at the same time? Or technetium bone scan and the gallium at the same time? Yes or no? Why do you say yes?
I think the energy is different, so you can't really do it.
Well, if you remember, we have 93 keV, 184 keV, 296 keV, and 396 keV.
Usually we don't use 93 though.
Well, we use actually the 93, the 184, and the 296 are the three that we do use. 93 is the most prevalent. That's actually one that they like. The problem is, no, we don't typically like to do them together because you have the higher energy scatter peak being picked up in the technetium window.
That's what I said, energy.
Huh?
Never mind.
So they are different energy, but the problem is, remember, you have that Compton scatter and stuff in there. Okay?
And you can't do, that was a gallium and a tech HMPO.
Right. I mean, you really shouldn't, because the thing is that you should do the technetium first, the shorter half-life first, and then you can inject the patient after that.
That's
But how about this one here? Which one should you use?
A.
Yeah, if you do the technetium by itself, then you need the 140, right? If you're using gallium, then you should use the medium energy. Okay, even if you're doing them, if they had them both together there. Okay. Now, the other thing here is the bowel activity. Okay, gallium is notorious for accumulating in the bowel because it does get filtered out through the liver. So it says it's always present, secondary to normal luminal activity, because remember you have the gallium being transported by the transferrin. Infection, the gallium will be retained in the wall, and that's why I said you have to do serial imaging to see if it moves along. If the gallium doesn't move along, then you know you have a bowel infection. Okay. And it says delayed images can be done up to 10 days. I don't think anybody more, I mean, the longest I ever went was 96 hours.
Yeah, wouldn't it be gone after that?
No, I remember it's got a long half-life, it's got a 3-day half-life, yeah. So if you injected 5 millicuries, and that's typically what we use, 5 to 8 millicuries. Normally for tumor imaging, they inject a larger amount because you don't do a early scan. You know, like I said, for an infection, you'll probably do 24 and 48 hours. For tumor imaging, you'll do 48 and 72 hours. Okay. And if you're looking for a tumor, then you're going to be giving like 8 millicuries. For an infection, you're probably going to be giving anywhere from 3 to 5 millicuries. So you give a lower dose for infection, higher dose for tumor imaging. Okay. Should a bowel prep be used in gallium scanning? Yeah, but it depends too, because if you have a patient that possibly has a bowel inflammation, you may not want to use a prep because you can cause perforation and things like that to them.
Or if they're EUNs.
Well, the BN wouldn't be a factor unless you were considering using, citrate of magnesia as a bowel prep. Okay. But here's the thing. Okay, so we said gallium does resemble iron. If you look at the periodic chart, you'll see that it's on the same column as iron. Okay. Binds to transferrin. Okay. Now, this lactoferrin, if you have an accumulation of white blood cells around an infection site, what will happen is the gallium gets drawn off of the transferrin and into the lactoferrin that's surrounding the white blood cells. Does that make sense? This part down here where it says binds to lactoferrin from leukocytes, this is the main mechanism of localization for gallium to get into an infection. Okay? So the lactoferrin causes it to come off of the transferrin and it stays in there. But the other thing is, who knows what a cytopher is? You heard of that before? Ashley, same?
Pores in the bacteria, let things in and out, like pores.
Kinda. Mr. Singh, have you guys heard of that before, or Ashley? No. Okay. Bacteria, in order to survive, need iron. So cytophores are products that bacteria produce to steal iron from the hemoglobin of blood cells and also from transferrin. Okay? So that's what a cytopher is. So lactoferrin and cytophers are what allows gallium to be taken out of circulation and accumulate at a site where there's an infection going on. Does that make sense now? A little bit better? Okay. You'll probably see the cytophores on there again, but this lactoferrin is an important concept though, because that's secreted by leukocytes. And then, like I said, bacteria will steal iron in order to survive. Okay. So here's an interesting question. Can gallium be useful in a patient who is leukopenic, or if you have what they call a sterile abscess?
No.
The answer is yes, you can. The reason why is because it's not relying on a bunch of white blood cells to accumulate. Okay. Right. You couldn't do HMPAO, you couldn't do, so gallium can be used for that. Okay.
Nor aminoxy.
Yeah, no. The white blood cells are not going to go, if you have a patient that doesn't have enough white blood cells, okay, then this may be your only alternative is to do gallium scan. Because gallium scans may be positive in leukopenic patients and sterile abscesses. Because of this, it says it binds to the iron-binding proteins from the inflammatory cells, cytophores from bacteria, or other metal-binding proteins at the site of the infection. Okay? So, if you have a situation where you have a patient that has a chronic infection, this is your better choice of radiopharmaceutical. But only in acute infections can you use white blood cells. Okay, so here we have an interesting situation here. With gallium, how do you know that this is a gallium scan? Normally, okay, you're gonna see the lacrimal ducts, you're gonna see activity in the sinuses. We normally see activity in the bone marrow and liver, sometimes in the spleen. On delayed scans, we do see activity in the bowel. Okay. So, I'm going to put Mr. Andy on the spot here. Mr. Andy, what do you think is going on with this patient? Start at the top. Anything other than, I mean, we see symmetrical activity in the lacrimal ducts, so, yeah.
It's less energy in the lungs.
Okay, activity in the lungs. It's not symmetrical activity in the lungs either, is it? And it's a 48-hour scan, so the activity in the bowel, that's kind of hard to call right now because, you know, if we did another scan at 72 hours, we might see that this stuff moves along. Okay, but the lungs are definitely an issue. Okay, it says 4+ pulmonary uptake and increased colonic uptake. Okay, those are the two big things that we notice right away. There's activity in the colon, and there's activity in the lungs. Patient has HIV, and this is a very consistent pattern for, what's PCP?
No, that's easy.
Okay, this is pneumocystis pneumonia. Okay, this is a fungal pneumonia that's very common with HIV patients. Okay, so that's what you're looking at. This is pneumocystis carni, lung infection. And in this case, pneumocystis carni pneumonia. So PCP is that this patient's not doing very well. Put it mildly. When the AIDS first came on the scene, we used to see a lot of patients with this problem. And one of my good friends was a technologist up in, her name was Frances Magley. She worked up in San Francisco, and she was almost an expert on this. Used to have her give talks all the time on PCP. You don't see it as often anymore, but it can still happen. Okay. Yeah. The other thing is, okay, when is the gallium scan preferred in spinal infections? Okay. So you got something going on down here, right? Again, with gallium, remember you'll see probably some salivary gland, lacrimal ducts, bone marrow. Okay, liver, a little bit of spleen. So what do you think? We definitely have something going on here, right? Okay. Now notice it says if the disc space, vertebral body, or infection is suspected, that's the best way to do that. The reason being is anything other than that doesn't have a direct blood supply, does it? Normally anything else gets its blood supply from cerebral spinal fluid, the spinal canal. But if it's a disc space or body that's infected, then it will have enough blood supply for the gallium to get there. Okay. This is another thing here, okay. These are some new antibodies that we talked about, this anti-CD15 approved for appendicitis. It's still being approved. Nobody's seen it out there yet. But I told you that antibodies, and which type of a cell produces antibodies?
B.
Was it, okay, it was B lymphocytes, right? So the B lymphocytes are the ones that are producing antibodies. So is it, what do you think it is? IgE, IgM, IgG? That's probably IgG. Okay. IgM is the one that's sort of like the generic type of immunoglobulin, and it will temporarily protect you during the initial attack, but then specific antibodies would be the IgG, I'm sorry. Okay. Here's a good example here. Okay, anti-CD15 MOAD. MOUSE. Yeah, what is that? Okay. So it's the M stands for murine, which means mouse antibody, right? Okay, so, and right down here is your appendicitis.
So they already done it?
Yeah. Oh, they've been doing this for, I mean, they haven't released it. I mean, we had this stuff called Nutrispect, which was a technesium, it was basically technesium HMPAO for labeling white blood cells specifically for acute appendicitis. But apparently some patients died from it. Well, I mean, the patients were in bad shape. But because they died and someone attributed it to the HMPAO, they sort of held off. They pulled it from the market. So the thing is, during clinical trials, fun things like that happen. Okay. Now here you go. Osteomyelitis with the knee bone. And again, white blood cells are usually pretty good for an acute infection. But remember, again, more than likely you'd probably start out with a 3-phase bone scan. And then with the 3-phase bone scan, if this was truly osteomyelitis, what would it look like? What would the flow phase look like?
It would be,
Okay, flow would be hot on the infected side. What about the blood pool? Okay, hot. Okay, what about the delayed image?
What are you asking? Osteo?
Okay, yeah, for osteo it's hot, hot, and hot. Okay. For cellulitis, it's hot, hot, and cold, right? Okay. Crohn's disease. You guys ever heard of Crohn's disease? This is again an inflammation of the bowel. It's not a very pleasant disease to have. But here you can see what it looks like when it's lighting up with our technesium CD15. I don't know when it's going to be released or if they're going to release it, but how about FDG? Because we're going to be talking about PET when you guys get back from lunch.
we're staying all day now?
Didn't you know that?
No.
Till 3 o'clock.
Mm-hmm.
Were you guys, what about Fresno? Were you guys planning on being here till 3 o'clock?